There's an insidious continuing threat to our membership over which we have no control, and it's escalating. Employed physicians. It's estimated that in 2014, 80% of us will be employed. And employed physicians as a group don't feel that they need the LSMS as a protector. They have an employer that takes care of those responsibilities. And so we have tasks. First of all, we got to go home and help our peers and friends know that the LSMS went to the AMA delegation with our delegates and lobbied heavily and well for their cause in terms of health care reform, but fell on the short side of an issue that's resolved democratically. The majority wins, the AMA moves on, and we disenfranchise ourselves. The LSMS represented you well. We need to be sure the rank and file know that and come back into membership. If you're not a member, you're not represented, and it is serious now. We have to have members. So we can't proceed either doing just like we've always done. We've got to be innovative, and you'll have resolutions before you today and tomorrow that involve hard work on the part of your council on membership. They're trying to find ways to do it differently. And you all will be able to take pot shots at it. You'll be a think tank for new ways for us to move forward, to break this trend, to stem the tide, and make membership, again, valuable to all of these parties, employed or otherwise. We've worked with a pilot study, working with groups through their administrative aides, through their non-physician directors, and it's been pretty successful. Groups where one or two members were previously members of our organization now are fully invested in our organization, and we've learned that these non-physician people are good access to memberships, and we need to carry this forward across the state and plan to. But other innovations are required. Please, as you look at the resolutions before you that apply to this, take them seriously, because your help is needed. We dealt with CCNs a lot this year. Many of you are primary care doctors. Many of you are in the field. As a matter of fact, the group we represent the most right now are independent doctors out there struggling to deal with our Medicaid population, which is growing. It's going to grow dramatically over the next 4 years. And the problem's only going to get worse because funding's not going to increase. So per member per month problems are already current and may well escalate. An underfunded system that's mandated to be managed care, which we have experience with. Keep doing the same thing over and over again and expect different results? Well, maybe, but it's going to be tough. So we went 2 years ago we heard about CCN initiatives from DHH through the grapevine. We heard it from you, from our doctors. We hadn't even been contacted. In fact, we learned then that nobody in organized medicine had been contacted. We reacted appropriately. We threatened suit against DHH. We sent them a letter and told them so. We were going to sue for failure to provide adequate access to care for Medicaid patients. All of a sudden, we communicate well. We're getting calls every day. They're asking us advice. And one of the things that spun off of this at first were the public hearings. We had a great success with public hearings because we went to them, our patients went to them, and DHH began to realize they can learn from people out in communities, from physicians working in the field. And they began to modify their approach to CCNs appropriately within the context of what the governor would allow, managed care and underfunding. We started to fund the work of a group called PAR. It's the Public Affairs Council, Research Council. This is a group of knowledgeable stakeholders who work to develop research products that help in matters of public concern, including health care. And they've been tremendously helpful to the agenda of the Louisiana State Medical Society because their research findings support what we already knew, but give us validity in governmental realm. And early on, they helped us develop a system to to qualify the insurance companies who wanted to run our CCNs. The request for proposal system spun off of work done between PAR and the LSMS so that we could help DHH pick, hopefully, at least from among the willing providers, the best ones. And in addition, early on, we learned from PAR research that some states were not careful in the way to design contracts, and 85% is required to go into healthcare was in fact usurped in part for administrative cost and for profits. And that wouldn't happen here because we alerted DHH to that, and contractually we're being very careful to that at least 85% of every Medicare dollar goes to the performance of healthcare for our patients. Farther, later, PAR did additional research. They went to 35 states that used managed care models for their Medicaid product and found glitches throughout their research. We brought those glitches to the table here in Louisiana so that our DHH won't make the same mistakes, and largely this falls into the category of transparency. These owners of these CCNs in other states have hidden some of their administrative costs in medical care through contractual tricks of the trade. Hopefully things like that are not going to happen here. Of course, our governor vetoed the effort by the legislature to have transparency for our CCN providers, but it won't happen because of the governor, not because of DHH. And DHH has reacted appropriately. They are going to provide transparency instead until we can arrange somehow to get legislative transparency. They're going to look after the quality of care that's provided and the way it's physically provided. They're going to protect our physicians and our patients from the activities of insurance companies that are unwieldy. How about medical professional liability? You know, last year we came to you. We had stakeholders of like mind, knowledgeable people in our insurance industry, the PCF, Lamico, and also Elliott Baker, who's attorney for the PCF in matters that relate to the cap at the Supreme Court level. And they were worried. We have 3 cases, appellate court cases, where our cap is challenged on the one hand, and there's a new twist, inadequate remedy. Not the cap necessarily, but insufficient funds to adequately award injured patients based on the cap being where it is. And so these threats led these knowledgeable people to come to us and say, we think you guys should preemptively raise the cap through the legislative process. And we were concerned. We brought it to you. We had a straw poll, if you remember. Unanimously, you decided last year to hold the course unless crisis became a problem. The discussion that followed that, though, sent your Board of Governors to the table. We continued to work with the stakeholders I mentioned, and we developed a packet, a source of information. We have insight, we have tools, we have data, we have numbers, we have ideas from all of these stakeholders, and they're well in hand and make us a little more comfortable that we could react quickly should crisis arise. The problem is that crisis means different things to different people. For example, I'm very concerned. I think we're in crisis. That doesn't mean I think we should raise the cap, but I think it's more critical than rank and file feels it is. The truth is, we have information, we're ready. Legislatively, we're okay. Our lobbyists tell us that there's no current crisis there, and even if something came up, legislatively speaking, we would still have time to react through the sluggish legislative process. But we could wake up one day and read in the paper that we're too late already because of a Supreme Court action. The Supreme Court's acting right now on one of those 3 cases. In deliberations as we speak, our lobbyists are attending those. It's scary. Where's crisis? How do you define it? I will say this. Our advisors in the insurance area, Lamico and the PCF, have put their pencil to it, and they feel that preemptively we could even double the cap and still maintain a premium structure manageable. On the other hand, they tell us that if we miss our chance and it's thrown open to decide, the insurance industry will come hard. We will lose all of our providers except Lamico and the PCF. Not only that, they will have to prepare for the worst case scenario, maybe even retroactive cases thrown into the system, so that premiums will create problems for patient access to care because doctors are going to go to safe havens for tort or retire early. I'm not here to scare you. I'm just here to try to put the facts on the table. And we need to be very alert to this, and I think this is one of the problems for Andy and his group. One thing your leaders will not do, they will not go against grassroots opinion. But we will try to keep everybody educated through leaders like you so that grassroots can come along with their definition of crisis as they see it. I want to finish by expressing my thanks to everybody who works at the state level for you and I in the LSMS. We have staff, unbelievable staff. We have volunteers, the Board of Governors, our councils, our councilmen, our AMA delegates. All of these people make this job so easy. If I had any success at all, it was as a facilitator of the extreme knowledge and combined wisdom and energy of all of those people. So I want to ask those people, the AMA delegates, our staff, the Board of Governors, all councilmen, all members of councils, please stand, if you will, together. There's more of you than that. And let's all express our appreciation to these wonderful people. Thank you very much. Well, the Medical Society is working very hard to keep the liability low. In other words, we don't want to waste money on professional liability. Many doctors spend over 20, even 25% of their income maintaining professional liability premiums, and we'd like to see that go away. We have a very favorable arrangement in Louisiana with tort laws that make it fair for injured patients while at the same time protecting the providers against undue losses. The other thing I would like to see is somehow we've got to be able to provide care for our Medicaid population. There's a tremendous change now in the way services are going to be delivered, and we want to make sure that our Department of Health and Hospitals, as well as our government officials, realize that it's underfunded, and we want to make sure that the way it's going with managed care is properly, transparently documented and held accountable for the care they provide.